Hello, good morning. I'm Ashok Kurokade, consultant rhinologist and endoscopic surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and endoscopic surgery webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So can I introduce Raj Bala? Raj is a great friend. He's a consultant rhinologist and skull-base surgeon from Manchester, and has a huge expertise in this area. He leads the Europe's largest MDT there. Very passionate about teaching, and he's a president-elect for BRS. So can I invite you, Raj, to introduce Claudio and host for the sessions? Thank you.
So, Ashok, well done on putting together a fantastic program and also assembling the faculty that you have. And I noticed Agnieszka's on the list of attendees, so she'll have been very pleased by that last video that you played. So can I introduce you to our colleague Claudio Callejas from Chile, who's going to talk to us over the next 20 minutes or so about endoscopic functional airway surgery. Over to you, Claudio.
Thank you very much. And thank you very much, Ashok, for the invitation. It's really an honor to be part of this Global Rhinology Network webinar. And in interest of time, I will focus on septoplasty and turbinoplasty. And probably the most important idea that I would like to stress about this talk is that a key to success when performing a functional nasal surgery is to choose the appropriate surgical technique. We have all heard the saying that when you have a hammer, everything looks like a nail. And the endoscope is a great tool, but just like any tool, if not used appropriately, outcomes won't be good. So endoscopic sinus surgery is a great surgical technique. It gives you a great view, but at least in my opinion, it's not always the best surgical technique to correct every septum. So it's key to be wise when choosing your technique. So as I said, in interest of time, I will talk about endoscopic septoplasty and powered endoscopic turbinoplasty. So let's start with endoscopic septoplasty. I will briefly talk about the indications to then focus on the surgical steps. And we could say that there are two main reasons to perform an endoscopic septoplasty. One is to treat nasal obstruction secondary to a deviated nasal septum in the context of functional nasal surgery. And the other one is to get surgical access when you are performing sinus surgery. And just like not every deviated septum is the same, not all deviated nasal septums should be treated the same. There are a lot of deviated nasal septums that are ideal to treat endoscopically, but at least in my opinion, there are others that are more easily treated and more effectively treated with a classic head-like technique, and others will require an open rhinoseptoplasty to be properly addressed. So how to choose? And at least from my point of view, the key is in the most anterior part of the nose. And I pay special attention to the anterior nasal spine and the nasal valve. We can see here in the left a septum that towards the anterior nasal spine is straight, as opposed to this one that is already deviated in the anterior nasal spine. And in this sort of septum that requires this articulation of the cartilage from the anterior nasal spine, where at least in my hands, it's much more easy to do this with a headlight and creating the classic 4 tunnels of Cottle. In both cases, however, I will continue my surgery with an endoscope. I think that the endoscope gives you such a great view that I use it routinely. So in a case like this, where we have a caudal luxation of the caudal end of the septum, but there are no lines of fractures, and actually the deviation is mostly because of an excess of cartilage. Using the classic head-like technique to remove the excess of cartilage, I think is the most easy and effective technique. However, I'm always watchful for situations like this one, where not only there is a caudal luxation of the septum, but also it curves towards the other side, and there is a collapse of the nasal valve. And you can see also that anterior line of fracture. So probably this deviated septum will require grafts, and personally I like to, or I prefer to refer these patients to my facial plastic surgeon colleagues to assessment for an open rhinoseptoplasty. So regarding surgical access, I think that the key point here is that it's important to have a low threshold to perform a septoplasty when performing endoscopic sinus surgery. I always like to see the axilla of the middle turbinate, the agarnacy region, and hopefully the olfactory cleft. And usually the CT scan underestimates the deviation. Here we can see a quite mild deviation. However, intraoperatively, we can see that there is a narrow space. I don't feel comfortable in a space like this to perform sinus surgery, and I cannot see the axilla of the middle turbinate, for example. So I think that if intraoperatively you are thinking, should I or shouldn't I make a septoplasty, the answer is do it. Here we can see after the septoplasty how there is much more space, and now I can see my olfactory cleft and I can do comfortable sinus surgery. So every time I consent a patient for an endoscopic sinus surgery, I also consent them for plus minus septoplasty, because I like to hold all the cards and be able to make that decision intraoperatively. So let's have a look at the steps. And I like to start infiltrating with a 25 gauge needle bended like in the picture with the vessel pointed up, because I think it's the easiest way to get into the supracondylar plane. And I will always do an anterior incision. It doesn't matter if the deviation is more posterior. I like to expose all the septum. And in order to do a long incision and have a good access, I raise the nasal valve with the dorsal part of my blade. I use a 15 blade. I know I'm always careful about this angle because I worry about scarring there, so I never go through the exact angle. And you can bring this incision all the way anteriorly, even to the mucocutaneous junction if you want. And it's important to scratch the cartilage. You don't want to go through the cartilage, but you want to scratch it because it's really important in any technique doing septoplasty to find the subperichondrial plane. So it's important to take time here and be sure that you're in the right plane. That will make the surgery much more easier. To make sure, I like to scratch the area of the incision with the sharp end of my freer, pointed the freer perpendicular to the cartilage. And in that way, I can make sure if I'm or not in the right plane. As you can see here, I wasn't in the right plane yet, but now that's the plane. So if you are in the right plane, you will have a quite bloodless dissection. As you can see, I'm just using the regular freers. I use the sharp end, and I always expose all the ipsilateral side of the septum, the cartilaginous and bony part. And it's quite straightforward, as you see when you're in the plane. In order to raise the contralateral flap, the cartilaginous osseous junction has to be disarticulated. And I think that it's important to protect the dorsal margin of your cartilage. And for that, I like to make an horizontal incision first before doing any vertical incisions to protect from unintentional extension of my vertical incision. So I'll do a vertical incision now, a few millimeters anterior to the bony septum to create some sort of window that will allow me to raise the contralateral flap. As you can see, always using the sharp end of the freer. And once we have created that window, it's really easy to raise the contralateral flap. And again, exposing as much as possible of the cartilage. Once the septum has been widely exposed, you can remove cartilage and bone on demand, always having in mind to protect the dorsal caudal margin of at least 1 centimeter. And the same that I did in the cartilage, I like to protect the bone or the skull base from unintentional extension of my fractures, doing an horizontal cut with a turbinectomy scissors superiorly. And that will prevent unintentional fractures causing a CSF leak. So it's important to check every now and then if you are in the right path, if you have removed all what you wanted to remove. For example, here I cannot see the axilla of the middle turbinate yet, so I had to remove more tissue superiorly. As I'm quite posterior at the level of the axilla of the middle turbinate, it's safe to go higher. That's important to know. And the septum at this level usually is quite thick, so I like to use a rough forceps like Airway Moore or Jensen Middleton to remove it in a controlled manner. And you can see how now I have a good view of the axilla, agar-nasal region, and olfactory cleft. To finish, I use a quilting suture, but always I think it's really important to check for the hemostasis. You want to have a dry fill, and if you are not really comfortable, I think it's good to have a low threshold to perform a drainage incision. Because if not, you may have pooling of blood in your septoplasty, and you will have swollen, or it will become swollen, or you will have an hematoma. So I have a low threshold to do this incision. I do it posteriorly and inferiorly to avoid pooling of blood. I think that a stab incision usually is not enough, so I like to create a significant incision, as you can see. I don't use nasal packing, but I use this quilting suture. I use a Vicryl 4.0 with a PS2 needle. And if I'm doing the septoplasty in the context of endoscopic sinus surgery, I like to put the stitch through the middle turbinates to prevent lateralization. And as this is a reabsorbable suture, after it's reabsorbed, the middle turbinates will return to their position. And to go through the turbinates, I think that the most easy way is to hold the needle like in the picture in a perpendicular manner. it could be a little tricky to go through the nasal passages, but if you do this jiggle movement, it's much more easy. And as you can see, then it's almost a rotational movement and you are through the turbinate and through the septum. For the rest of the quilting suture, I put the needle in the vertical axis, as you see in the video. And I think that a really important key point here is that you never follow the line. You don't ask your assistant to keep applying tension on the line, because after the surgery, the septum could get swollen and that could cause ischemia, necrosis, and you may have a septal perforation even if you don't tear the mucosal flap. And I remember I had a few of those, and actually was Alcisaltis that pointed this out to me. And since I stopped applying tension to my suture, I never had those like unexplained perforations again. At the end, I leave some sort of loop in one side that allowed me to put the stitch, to make the stitch. And again, it's really important to avoid doing a really tight knot because you don't want to cause ischemia. It's important to detect when you have spurs because you have an increased risk of having a tear in your mucosal flap. So it's really important to preserve the contralateral side. And the best thing, I think, is to leave the spur until the end, to remove it once you have a decreased tension in your flaps. In that way, you decrease the chances of tearing the mucosa. You can see here I'm raising the ipsilateral flap and I can feel the tension in my flap. So I will try to decrease this by removing part of the cartilaginous spur. This will release a little bit of tension and will allow me to keep raising my flap posteriorly. So here more advanced, I have already raised the contralateral flap. I'm above the spur there. You can see the spur in the tip of the freer. And again, to release some tension on the flaps, I will remove part of the bony septum. And here, as you can see, I left the removal of the spur until the end because all my flaps has been released and there's little tension on them. So just now I'm raising the mucoperiosteal flap below the spur. And now I will do an horizontal incision below the spur. So in this way, more than dissecting the mucosa away from the spur, what I will do is push the spur away from the mucosa. And in this way, I decrease the tension on the flaps. And in that way, I decrease the chances of tearing the mucosa, or I will have a small hole. And the other thing that I like to do is rotate the spur, as you saw. This often helps to detach it from the mucosa without tearing it. Or you may have a small tear, but nothing significant. So that are the surgical steps of the septoplasty. So I will move forward in the interest of time, and I choose to talk about the power endoscopic turbinoplasty because I think that is the most effective of all the techniques. It's quite straightforward. Basically, what you have to do is to remove the inferior mucosa of the middle inferior turbinate with your microdebrider, and then to elevate medial mucocutaneous flap. Sorry, a medial mucosal flap, and then resect inferior strip of the bony turbinate with the lateral mucosa attached to it. Then roll your medial flap to cover the exposed bone, and finally you can out-fracture the turbinate to get more space. So you start by infiltrating the head of the inferior turbinate. I don't really infiltrate the whole turbinate. And before removing the mucosa of the inferior edge, I'm always watchful of this angle. I don't want to put my microdebrider there because I'm worried about scarring in that area. And I start from the anterior part all the way posteriorly onto bone, just in the edge. Usually it's better to leave your endoscope in the entrance of the nose because this could be quite bleedy and it will get dirty with blood. It's important to look upward with your microdebrider. You have to point upward because you don't want to injure the soft palate, and always have in mind the sticking too. To find the plane, I think that it's useful to create this little window in the posterior aspect of the head of the inferior turbinate onto bone, and in that way it's much more easier to find the plane. And I usually use a Joseph or the sharp end of the FLIR to find the superosseal plane, and then change to the malleable suction FLIR from the Wormald set, which is quite handy to raise the rest of the medial mucosal flap. I usually don't look actively for the arteries, but if I found an artery, I will perform cautery to decrease the bleeding. I haven't fractured the turbinate yet because I want a stable turbinate. I think that raising the flap from a steady turbinate, it's much more easy than for a floppy turbinate. So after I raise the medial flap, I'm going to fracture the turbinate medially to leave it in a more comfortable position to resect this inferior strip of bone. Here we're looking at the inferior meatus, and we can see the lateral mucosa attached to the inferior turbinate. We can see the medial flap. So now we're ready to remove the inferior strip of bone, and I use my inferior turbinate scissor. It's important to avoid doing just one long cut because, as you can see in the picture, probably you will reset most of the turbinate. You want to do small cuts, and every time before cutting, pulling the tip of the scissor inferiorly. In that way, you will resect a strip of bone instead of most of the turbinate. And then for hemostasis, I like to use the suction monopolar, which is disposable, and you can bend it, so it's quite comfortable and easy to perform hemostasis. Use it in 20. Mostly in the posterior part of the turbinate, you have to focus because it could be quite bleedy. And then to get more space, I outfracture the turbinate, and then I will roll the mucosa over the inferior edge of the turbinate to cover the exposed bone. To hold the flap in place, I use a Surgicel. I measure the length with a sphere. I want to cover the whole length of the turbinate, and the width is around 1.5 centimeters, usually the height of the turbinate, as you could see. Before rolling the Surgicel over the turbinate, I like to make sure that it's not folded, accommodating the Surgicel against the septum, as you saw. And when I'm positive that is in the right place, I will roll it over the inferior turbinate. Paying special attention to leave the, or preserve the inferior edge of the turbinate covered with the flap. And as you can see, at the end, we have a nice nasal passages that can be seen from the anterior part of the nose. So very briefly, some concept that I would like to stress about septoplasty specifically is that it's really key to get the best results to choose the appropriate surgical technique. I think that key areas to evaluate are the nasal valve and the most anterior part of the premaxilla and anterior nasal spine. Have a really low threshold to perform septoplasty when doing endoscopic sinus surgery, and to avoid complications. Of course, avoid having mucosal tears bilaterally, but really important is change my practice. Never follow the line. Don't do your quilting suture with too much tension. Don't do a tight knot. If you are not entirely happy with your hemostasis, have a low threshold to perform a drainage incision. And of course, before removing bone or cartilage, do an horizontal superior incision with scissor or your FLIR to avoid an intentional extension of your incision or fracture to the skull base. And that's it. Thank you very much.
Thanks, Claudio. Great work. Lovely, clear presentation. Okay, septal and turbinate surgery. Okay, so just a couple of quick questions. So how do you manage a very high deviation which obstructs the middle turbinate axilla?
Yeah, that's a great question. So if you have a really high anterior deviation that is collapsing the valve, I think that patient will probably require a spreader graft, and I would refer that patient to a facial plastic colleague, as I said. But if the deviation is high at the level of the axilla, that's really safe. If you, we have heard all this talk about draft 3, for example, and they are actually drilling at the level of the axilla, reaching the frontal sinus. So at the level of the axilla, you can take your resection of bone all the way up. So it's not a problem, it's safe. You are quite far from the osteocartilaginous junction. So I usually play safe. So the first horizontal cut in my cartilage, I leave at least 1 centimeter, but then I check with the freer the depth where I am. So I put my freer through the nose and I touch the axilla of the middle turbinate, and then I will put it through my dissection flap, through the dissection plate, and I can see the depth where I'm pretty safe and take all the septum upward. So it's quite safe, that area.
Thank you. Okay, and then the next question you've actually answered in your presentation. So Martin, I think you saw Claudio remove the septal spur endoscopically rather than switching to a headlight and speculum. And a swollen septal body, is that something that you address? That's another question.
Yeah, that's a good question also. As I show in my video, when I start an endoscopic sinus surgery, usually the septal body is quite swollen. So I would try first to decrease that with adrenaline. But if I still cannot see the axilla, and even if the septum doesn't look too deviated in the CT scan, I would do a septoplasty. Because to perform a comfortable endoscopic sinus surgery, especially to go to the frontal, I want to see the axilla and hopefully the olfactory cleft. And if it is a narrow nasal passage, even if the septum is straight, I would do a septoplasty because I could mobilize the septum. So,
thanks, Claudio.
yeah.
Great work. Lovely. Beautiful presentation as well. Thank you.